Welcome to the completely new discussion on thyroid gland. Thyroid gland is a really important topic for exams because this is one area where the examiner loves to ask the question. So you have to be thorough on the thyroid gland in every inch about the gland. So we are going to see in detail about the thyroid gland for the next few lessons. And at the same time, this video is going to be on the basics of the thyroid gland. Especially we are going to discuss on the basic anatomy and the embryology of the gland. In the next video, we'll be discussing on the physiology of the thyroid gland. But if you feel that you're really confident about this embryology, anatomy, and the physiology, then you can skip this video and you can directly move on to the functions and the disorders of the thyroid gland. But if you feel like you are a little bit lagging and if you want to know more information from my perspective, so you can please watch this video. And with this, we can kickstart with the anatomy of the thyroid gland. So first, you know that the thyroid gland is going to be on the lower anterior portion of the neck, which is a butterfly-shaped gland, and the usual extent of the thyroid gland is from C5 to T1. Very important question. So they're going to be in the vertebral segments C5 to T1. So this is a usual level of the thyroid gland. Then, if you see the relationship of the thyroid gland, you have anterior, medial, and posterior relationships predominantly. That's what you're going to see. The anterior relationships are made by the strap muscle. The strap muscles contribute to the anterior relationship to the thyroid gland. So what are the strap muscles? These muscles are the ones that are very important in the anterior surface of the neck, and without these muscles, probably your anterior surface of the neck may go for a toss. So why I told that? Because the mnemonic for remembering these muscles is TOS. T stands for thyroid, O stands for omohyoid, S stands for sternothyroid, and S stands for sternohyoid as well. So these are strap muscles that are going to form your anterior relationship with the thyroid gland. And similarly, you have a medial relationship of the thyroid gland, that is nothing but the trachea and the esophagus. These two structures form a very important component of the medial surface of the thyroid gland. And they also have relationship with two important nerves. Obviously, the nerves of the larynx are going to be related with the thyroid gland on the medial side. So one is going to be the recurrent laryngeal nerve, all right, and the second is going to be the external branch of the superior laryngeal nerve. So these are the two nerves that are going to be related to the medial portion of the thyroid gland. And this is really important to understand as well. And next, on the posterior portion, so you can see this is the posterior aspect of the gland. You're seeing the gland from the posterior side, which means this is going to be the left and this is going to be the right. And in the posterior aspect, you can see the parathyroids have a very important relationship, which means these parathyroid glands are going to be present on the posterior side of the thyroid gland. At the same time, you have a carotid sheath that contains the vascular structures and the neurovascular structures. This is nothing but the carotid artery, that is common carotid artery, not the internal or external, and your internal jugular vein along with the vagus nerve. So this vagus is also going to be on the carotid sheath only. So this forms a very important posterolateral relationship with the thyroid gland. At the same time, you can see thyroid is enclosed by a very important fascia. This fascia is what we refer to as a pretracheal fascia. What I am drawing here, I will highlight also. This is what we refer to as this pretracheal fascia, and the thyroid is invested along with the pretracheal fascia. And you also have a fibrous capsule along with the thyroid gland. Thyroid gland itself has a capsule, and it's very important to note that the posterior aspect of the capsule becomes thickened, and it's going to attach with the cricoid cartilage and to a lesser extent with the tracheal rings and mostly with the cricoid cartilage. And this thickening of the thyroid capsule and its attachment with the cricoid cartilage is what we refer to as the Berry's ligament, or something we call it as a suspensory ligament of Berry. So this attachment is the one that prevents the thyroid from sinking downwards towards the mediastinum. At the same time, this is the one that is going to make the thyroid, that is going to give rise to a characteristic clinical feature that thyroid moves with deglutition and swelling. So all this is because of this suspensory ligament of Berry, which is going to make an attachment of the thyroid with the trachea and the cricoid cartilage. Clear? So this is a very important concept to understand. So after knowing this important basic anatomical relationships, let us move on to the arterial supply and the related nerves that are associated with the arterial supply, which is even more functionally important because of the surgical anatomy we have, and it's going to be a regular question in your exams. So let us move on. to the arterial supply of the thyroid gland. So what are the arteries that are going to supply the thyroid gland? You have two basic arteries. One is the superior thyroid artery. So this is the superior thyroid artery, and it is actually cut here in this diagram. So this is the superior thyroid artery. I can write it down. This is the superior thyroid artery, right? So where this superior thyroid artery is going to originate from? This superior thyroid artery is going to originate from the external carotid artery. From there it originates and supplies the superior portion of the thyroid. They are going to supply the superior portion of thyroid gland. Along with it, they are also going to supply the superior parathyroid glands. Yes. What is the second major artery? Second major artery of the thyroid gland is the inferior thyroid artery. So this is going to be the inferior thyroid artery. And let me tell you this. So this is the inferior thyroid artery, and if you trace out the inferior thyroid artery, it doesn't originate from the carotid. Instead, it originates from the thyrocervical trunk. So this is going to be the thyrocervical trunk, which is itself is coming from the subclavian. So this is the thyrocervical trunk, which is actually going to originate from the subclavian. Clear? So this is again a very important artery. And there could be a third artery which can probably originate from the arch of the aorta or the brachiocephalic trunk. So that is what we refer to as something called the thyroidea ema artery. Thyroidea ema artery. So which can actually originate from the brachiocephalic trunk or maybe originate from the arch of aorta. So if it is present, not in all the case, if it is present, they will supply the anterior surface of the thyroid along with the isthmus of the thyroid. Anterior surface of the thyroid along with the isthmus of the thyroid. This can be supplied by this thyroidea ema artery. But the two major arteries are going to be the inferior thyroid artery and the superior thyroid artery. We didn't tell you the inferior thyroid artery what's going to supply. The inferior thyroid artery is going to supply the inferior portion of the thyroid. They are going to definitely supply the inferior portion of the thyroid gland. Along with that, they will also be supplying the inferior parathyroid gland. Inferior parathyroid gland. And next important thing is the drainage, venous drainage of the thyroid gland. Venous drainage of the thyroid gland comes from three important veins. One is the superior thyroid vein, second one is the middle thyroid vein, and third one is the inferior thyroid vein. Please do remember this superior thyroid vein and the middle thyroid vein are going to reach the internal jugular vein on either sides. At the same time, this inferior thyroid vein is going to drain into the brachiocephalic veins on either sides, on the right and the left. So superior and middle to the inferior internal jugular vein and the inferior thyroid vein to the brachiocephalic trunk. So these are the important venous drainage. Then you know the nerve supply, the innervation of the thyroid gland. The nerve supply is very simple and straightforward. Parasympathetic wise, obviously it's a no-brainer. It will be obviously supplied by the vagus. There is no doubt about that. But whereas the sympathetic supply is going to come from the cervical sympathetic chain, especially it's going to come from all the three cervical ganglions, that is the superior, middle, as well as inferior cervical ganglion. Clear? So this is the sympathetic supply of the thyroid. But the other two nerves are really important, even though they don't really supply the thyroid, and these nerves are important for the laryngeal supply, but these have a very, very close relationship with the thyroid artery. So especially they are prone to get damaged during surgery. That's why it's important to know about the other two nerves, that is the recurrent laryngeal nerve and the superior laryngeal nerve, especially the external branch of the superior laryngeal nerve. Because the internal branch of the superior laryngeal nerve has no much relationship with the thyroid gland. That is very important again. The external branch of the superior laryngeal nerve is what is going to have a very decent relationship with the thyroid gland. Fine. So you can see these two nerves, which I can show here. So this is the recurrent laryngeal nerve, which is mentioned here. So this is the recurrent laryngeal nerve. You can see that is having a very close relationship with the inferior thyroid artery. And similarly, this external branch of the superior laryngeal nerve. So this is the internal branch that's going here. This is the external branch of the superior laryngeal nerve that is having very, very close relationship with the superior thyroid artery. So that's why these relationships are really, really important. So before going into what they actually have in the relationship, but we also have to know what they supply. Suppose you have your vagus that goes up to the midgut, isn't it? Till the end of the midgut, it's going to supply till the abdomen, and most of the viscera, the parasympathetic supply is going to come from the vagus. But before that, let us see in the larynx what they do. They give rise to two important nerves. One is the recurrent laryngeal nerve, and second one is the superior laryngeal nerve. And this superior laryngeal nerve, we have this external branch and we have this internal branch. And the recurrent laryngeal nerve is going to supply all the intrinsic muscles of the larynx. So many of the intrinsic muscles of the larynx will be having that arytenoid component. So almost all of the intrinsic muscles of the larynx are supplied by the recurrent laryngeal nerve. But one important muscle is supplied by the external branch of the superior laryngeal nerve, that is the cricothyroid. And next, this internal laryngeal nerve has no muscular supply. So they don't supply any muscle, but they have sensory innervation. So that is why this is important. They have that sensory innervation. So where they are going to supply? They are going to supply sensory innervation above the vocal folds or above the larynx, above the vocal folds. But how about below the vocal folds? So this recurrent laryngeal nerve itself is going to take care of the sensory also. So the sensory innervation below the vocal folds is actually done by the recurrent laryngeal nerve itself. So if you take only the sensory innervation, you can take the vocal folds. So above the vocal folds, it's going to be internal branch of the superior laryngeal nerve, and below the vocal folds is going to be the recurrent laryngeal nerve. We know that. But what about the vocal folds itself? Vocal folds itself gets from both these nerves, which means vocal folds by itself, they will be supplied by both internal branch of the superior laryngeal nerve. At the same time, they will be supplied by the recurrent laryngeal nerves as well. So they have this dual sensory supply. But remember, all the intrinsic muscles of the larynx are actually supplied by the recurrent laryngeal nerve, and only one muscle that is supplied by the external branch of the superior laryngeal nerve is the cricothyroid muscle. But do remember, this recurrent laryngeal nerve as a function of abduction as well as adduction. We'll see that later on, whereas cricothyroid is important for the tone of the voice in the first place. So the tone and the pitch is very important, because this cricothyroid muscle is like a tuning fork for your throat, so which means it raises the pitch, and for that your cricothyroid muscle is really, really important. Whenever you damage the recurrent laryngeal nerve, you know what you are going to result in. You are going to result in hoarseness of voice. Similarly, if you damage your external branch of the superior laryngeal nerve, you will lose the tone of the voice, which means you cannot raise the pitch of the voice, which will result in husky voice. Whenever you try to raise the pitch, your voice will become husky. So this is the problem you will result if you have damage to external branch of the superior laryngeal nerve. Remember, this recurrent laryngeal nerve is usually damaged near the inferior pole of the thyroid, because it has its close relationship with the inferior thyroid artery. Similarly, this external laryngeal nerve has a close relationship with the superior pole of the thyroid and the superior thyroid artery. So that's why it can be damaged during thyroid surgeries when you are manipulating the superior thyroid artery. Remember, the internal branch of the superior laryngeal nerve is very, very difficult to get damaged, because it has no close relationship with the thyroid gland at all. So even in surgeries, this internal branch of the superior laryngeal nerve is very, very difficult to get damaged. So that's what you have to understand in the first place. So since these nerves are at very high risk of getting damaged during thyroid surgeries, it's also very, very important to know the relationships and where you can find these nerves in the thyroid surgery. That's why they are going to define a lot of triangles. So to identify the recurrent laryngeal nerve, basically you have 4 triangles. The most important one is the BR triangle, and the second important triangle is going to be the Simon's triangle, and the third not so important triangle is the RLN triangle itself, and the fourth again not so important triangle is going to be the Lowe's triangle. Lowe's triangle. Similarly, for identifying the superior laryngeal nerve's external branch, to identify the external branch of the superior laryngeal nerve, you have one very important triangle that's important for exams. That's called the Joel's triangle. You would have heard about the Joel's thyroid retractor, which is very important for retracting the structures during thyroid surgery. But that name is there. You have a Joel's triangle. And another very important classification you have to know about the external branch of the superior laryngeal nerve is the Cernia's classification. All these things are exam questions for you. Apart from that, I'll also be discussing on the Reeves cricothyroid rhesus. At the same time, I'll also be discussing on the triangle of concern. So that's also I'm going to draw it with these diagrams. So let us see what about the BRs and your Simon's triangle. So these two are very important. So BR and Simon triangle is defined in this particular area. So first you have this inferior thyroid artery. So I can tell this is the inferior thyroid vessel. This is going to form the superior part of the triangle, and the medial part of the triangle is created by the recurrent laryngeal nerve itself. You can see this is the RLN, which is yellow in color. So this is going to form the medial part of the triangle. And you can see this common carotid artery itself form the lateral part of the triangle. So this is what we refer to as something called a BR's triangle. So this is the BR's triangle which I have drawn. So remember, in BR's triangle, the recurrent laryngeal nerve is the one that forms the border of the triangle itself. But you have another triangle which is going to be called as Simon triangle. So what do you mean by Simon triangle? Almost similar landmarks, but only one part of the triangle's landmark will be different. So that is the medial part. So the superior again is going to be the same. That is the inferior thyroid artery, and the medially there will be a tracheoesophageal groove. But remember, in this the medial part will become the tracheoesophageal groove. Remember, the tracheoesophageal groove is the place where your RLN goes up, recurrent laryngeal nerve goes up. So that's a very important landmark again. And medial, once again, it's the common carotid artery. So there is no change. So here if you see, this is the triangle here. So this is the Simon's triangle which I have drawn. So medially the tracheoesophageal groove, laterally it's going to be the common carotid artery, and the superior part of the triangle will be the inferior thyroid artery and its association. So this is going to be the superior relationship. And you can see in the Simon triangle, the content of the Simon triangle itself is the recurrent laryngeal nerve. The recurrent laryngeal nerve forms the content of the Simon's triangle, whereas in the BR's triangle, the one of the borders of the triangle is the recurrent laryngeal nerve. So which means these two are very important triangles. This is where you see the recurrent laryngeal nerve very, very commonly. And you also know the importance of the recurrent laryngeal, why they are called as recurrent laryngeal nerve, because they are not going to be directly, like supplying the larynx near the thyroid itself. They go down along with the vagus and they come up again. That's why they call it as a recurrent laryngeal nerve. So for example, the right recurrent laryngeal nerve is going to arch around the right subclavian artery, and they're going to come up again and they supply the larynx. But on the left side, the left recurrent laryngeal nerve, and again all this is based on the embryological aspects of the aortic arches, so you have to be very thorough in that. So I'm not going to discuss in this video, but please be thorough on the aortic arches. So the left recurrent laryngeal nerve is going to go down and it's going to arch around the arch of the aorta and the ductus arteriosus. In adults it's not called as ductus arteriosus, it will be ligamentum arteriosus. So they're going to arch around the arch of the aorta and the ligamentum arteriosus, and they're going to come up and they're going to supply the larynx. So right arches around the right subclavian, left arches around the arch of aorta and the ligamentum arteriosus. So this is the basic anatomy of the recurrent laryngeal nerves. So which side recurrent laryngeal nerve will be most commonly affected? The question. So remember, the left side recurrent laryngeal nerve will be affected almost 2 times as common as the right sided recurrent laryngeal nerve. Remember, both recurrent laryngeal nerves can be affected during thyroid surgery, but left is also affected with many conditions like Ortner's syndrome because of left atrial enlargement and pulmonary hypertension, and your lung cancers and any other mediastinal problems, aortic arch aneurysms. Lot of these things can also affect the recurrent laryngeal nerve that is going, arching around the arch of the aorta, so that the left recurrent laryngeal nerve is affected by lot of more pathologies compared to the right-sided recurrent laryngeal nerve. That's why the left recurrent laryngeal nerve is going to be twice as commonly affected as that of the right-sided recurrent laryngeal nerve. Very important point. So we have seen these two triangles, which are very, very, very important for the recurrent laryngeal nerve identification. So now let us see the Jones triangle before going into the RLN triangle and the Lowe's triangle, which is itself not so important for exams and even for practicing surgeons. So the Jones triangle is really important. So where is the Jones triangle? The Jones triangle is somewhere here. So I can draw this triangle as something like this. So the medial side is going to be the midline itself, and the superior aspect of the triangle is going to be formed by the attachment of the strap muscles. So this is going to be the attachment of the strap muscles. You can see on the other side. So this is where your sternothyroid and thyrohyoid gets attached. So this is where the attachment of the strap muscles are. So that's going to form the superior aspect of the triangle. And on the lateral side, you're going to see the superior pole of the thyroid. This is the superior part of the thyroid gland along with the superior thyroid artery. This itself, these two structures are going to form on the lateral side. And if you see the content of this triangle, the content of this triangle is the cricothyroid muscle itself. Clear? The content of the triangle and the base of the triangle is going to be formed by the cricothyroid muscle itself. And the most important content of the triangle you can guess right now, because that's why we have been discussing about this triangle. It's going to be the external branch of the superior laryngeal nerve. So this is going to be seen in this triangle. So that's why this triangle is very important. So the most important content of the Jones triangle is going to be the external branch of the superior laryngeal nerve, where you can easily locate this nerve inside this triangle. So why these are important? Because this is very important for a surgeon who is operating the thyroid gland, because they have to avoid the injury to these nerves. Otherwise, you're going to result in a lot of bad consequences. That's why. At the same time, I have to tell you about the Cernia classification also. What do you mean by a Cernia classification? This will tell you the risk of injury to the external branch of the superior laryngeal nerve, depending on how close it is associated with the superior pole of the thyroid gland. So we'll put a horizontal plane at the superior pole of the thyroid gland. So let me draw a horizontal plane. So this is the horizontal plane at the superior pole of the thyroid gland. And Cernia classification tells, suppose if the nerve crosses the vessels more than 1 centimeter from the superior pole of the thyroid gland. So this is the horizontal plane that I have drawn at the superior pole. So compared to this plane, if the nerve crosses the vessels almost like 1 centimeter above this horizontal plane, more than 1 centimeter from this horizontal plane, we call this as type 1 anatomy. And this is the most common, seen in 65 to 70% of the patients, and they have a reduced risk of injury to the external branch of the superior laryngeal nerve. Suppose if it's located within 1 centimeter, less than 1 centimeter from the horizontal plane that is passing through the superior pole of the thyroid gland. So this is called type 2A, and this is not that common, but this is going to have a high risk of injury to the external branch of the superior laryngeal nerve. And there is another type where the external laryngeal nerve can pass below the horizontal plane itself. So if this is the case, then this will be called as type 2C, where the external branch of the superior laryngeal nerve will be passing below the plane of the line that is drawn on the superior pole. So this is type 2C, and this is going to pose the maximum risk of injury to the nerve. And these are the 3 important types. And remember, the most common anatomy that you see is the type 1 only, which is going to carry less risk for damage to the external branch of the superior laryngeal nerve. But type 2B is the one that's going to pose the maximum risk. Clear? There is another type called type 4, which is not described in many textbooks, where type 4 means the external branch of the superior laryngeal nerve can pass dorsal to the superior pedicle, dorsal, like it will posted to the superior pedicle of the thyroid gland itself. But if you know these three, it's more than enough. That is type 1, type 2, and type 2b, types of external branch of the superior laryngeal nerve. This is what we refer to as something called a Cernia classification. And before that, we have to define two more triangles. These are unimportant triangles. Just for namesake, for completion sake, I'm doing this. So one is the Lowe's triangle and second is the RLN triangle. So these are inverted triangles. So what do you mean by Lowe's triangle? In the Lowe's triangle, you have the lateral aspect to be on the common carotid artery itself. So common carotid artery will be the lateral aspect of the gland. And second one will be the inferior pole of the thyroid gland. So this is the inferior pole of the thyroid gland. So this forms the one part of the triangle, superior aspect of the triangle, and the lateral aspect will be the common carotid artery itself. So this is going to be the common carotid artery, and the midline on the medially, you have the trachea. The trachea is going to form the medial portion of the triangle. So again, the content of this triangle, you know very well, it's going to be the recurrent laryngeal nerve only. So that's going to be the content of the triangle. So this is what we refer to as something called a Lowe's triangle. So what is the difference between this and the BR and your Simon's triangle? So this Lowe's triangle is one of the first triangles that was described to identify the recurrent laryngeal nerve. But I mean, the BRs and Simon's are more practical compared to the Lowe's triangle, because Lowe's is a little bigger. In the Lowe's, you are using the inferior pole of the thyroid as the superior border, whereas in BR's and Simon triangle, you have used the inferior thyroid artery as the superior pole of superior end of the triangle. So we can see here. So you have ideally used the inferior thyroid artery as a very important landmark on the superior side. Whereas in Lowe's triangle, you have used the inferior pole of the thyroid gland itself as an anatomical landmark for the superior part. So this is the difference between Lowe's triangle and the BR and Simon triangle. Clear? And there is a second triangle, which is a very big triangle again. So that is going to be the RLN triangle. So in the recurrent laryngeal nerve triangle, it's a very big triangle. It's going to be the midline. That is going to be the on the medial side. So the medial aspect will be the midline itself. And on the lateral side, it's going to be the strap muscles. Usually during the thyroid surgery, you are going to retract the strap muscles. So this retracted portion of the strap muscles will be forming the lateral area. So the retracted portion of the strap muscles will be on the lateral side, and the apex of the triangle will be formed by the thoracic outlet or thoracic inlet, you can call it anyway. So this is going to form the apex of the triangle. So, and the superior portion of the triangle will be again the inferior border of the thyroid gland. The superior portion of the triangle again will be formed by the superior border of the triangle will be formed by the inferior portion of the thyroid gland or inferior pole of the thyroid gland. So this is a huge triangle you can see. So this is what we define as something called a recurrent laryngeal nerve triangle. Again, a very unimportant triangle, which means here is where you are going to see the recurrent laryngeal nerve very commonly. Clear? And again, more and more smaller the triangle is, more is useful for surgery, because it's all about precision, isn't it? The smaller the triangle is, more better predictability for seeing the nerve precisely in that particular area. So that's the reason why this Simon triangle and Bias triangle are more important compared to these two triangles. At the same time, this George triangle is more important for this external branch of the superior laryngeal nerve and for the locating that particular nerve in the surgery. So clear? So we have discussed in detail about the nerves that are in association with the thyroid gland. Now, I also have to tell there is some space. This is nothing but you can imagine like a Joul's triangle. In the Joul's triangle, once you take off the superior pole of the thyroid gland, and in the floor you are going to have the cricothyroid muscle. You can see in the floor you have this cricothyroid muscle, and you know the content of this triangle is going to be the external branch of the superior laryngeal nerve. But when you retract the superior portion or superior pole of the thyroid gland, you can see a recess-like space that is completely an avascular space. This is what we refer to as Reeves avascular space. That is Reeves avascular cricothyroid space, where there is a avascular recess that is located between the superior pole of the thyroid gland and the cricothyroid muscle. So, I mean, you can remember it in the similar fashion to that of the Joul's triangle also. But this is a avascular space because this area is not going to be associated with that much risk of bleeding. But there is one other area that is going to be associated with a very high risk of bleeding. That is called a triangle of concern. In fact, this is going to be the most common site of bleeding intraoperatively. Clear? This is called a triangle of concern. So where is the triangle of concern? For that you have to know this is something called the Berry's ligament here. So this forms the apex. And the lateral side is going to be by the recurrent laryngeal nerve itself. You know definitely this is the recurrent laryngeal nerve, and the lateral part of the triangle will be formed by the recurrent laryngeal nerve itself, and the medial part will be formed by the trachea. Medial part will be formed by the trachea itself, and the inferior part will be formed by the soft tissues. There is no defining feature. Inferior portion will be by the soft tissues, and probably one ligament called a thyrothymic ligament is also there. So that could form the inferior portion along with the loose tissues with fat and connective tissue will be forming the inferior portion of the triangle. So this triangle is what we refer to as the triangle of concern. So this is what we call the triangle of concern. Why this is a very important triangle? Because some small branches of the inferior thyroid artery are located in this triangle, which might go for bleeding during the surgery. And that's why achieving hemostasis in this area is really important. At the same time, you have to know that recurrent laryngeal nerve is in close proximity. So whenever you are achieving hemostasis with the cautery, you have to close the recurrent laryngeal nerve, probably with a Surgicel, and then you have to use the cautery or whatever hemostatic methods you are trying to follow during the surgery. So that's why this triangle of concern is again very important, which is the most common site of bleeding during the surgery of a thyroid gland. Clear? So now it's also important to understand about why these nerves are important, and these nerves are actually medically important for thyroid surgery because before the thyroid surgery, many times it's also important to prove the functioning of the vocal cords, because when you are going to damage during the surgery, patient might see you. So that is the reason you have to understand about the different nerves and what are the positions of these vocal cords as well, and what they do to the position of the vocal cords. So first, let us see what are the positions of the vocal cords that you are going to encounter in your exams. For this purpose, even during indirect laryngoscopy or direct laryngoscopy, you can see this position. But for my understanding, because I am a critical care physician, so I am going to look at a direct laryngoscopy when you are intubating the patient. So how will be the position of the vocal cords? So this is how the vocal cords are going to look. So this is the epiglottis, and this is the right side of the patient, and this is the left side of the patient, which means this is the right vocal fold and this is the left vocal fold, and this is how you are going to look at it. So with this in mind, let us see what will be the positions of the vocal cords and the vocal fold. So this position is what we refer to as a median position. It's exactly the midline, dead straight. And this position, we call them as paramedian position, which is typically at 1.5 millimeter from the midline. And this position, called as cadaveric position, it's around 3.5 millimeter from the midline, and this position is full abduction, abducted portion, that is 7 to 9.5 millimeter from the midline. So remember, median portion, paramedian portion, full abduction, all these things can be seen physiologically, but this cadaveric portion can never be seen physiologically. For example, this median portion can be normally seen during phonation or even during a recurrent laryngeal nerve palsy. Alright. This paramedian portion can be usually seen during a quiet whisper. When you are whispering, you can assume a paramedian portion, or you can even see during a recurrent laryngeal nerve palsy, which means during a recurrent laryngeal nerve palsy, depending on whether it's complete or whether it's incomplete, you might be seeing the position of the vocal folds either in the median or paramedian portion. Clear? Full abduction is usually physiological, which means you will usually see during respiration. Normal respiration, you can see the full abduction. 7 millimeter when you are quietly breathing, and 9.5 millimeter when you are forcibly breathing. When during forced inspiration, it can abduct very nicely. But this cadaveric portion is almost always pathological. Whenever you get a cadaveric portion, it always indicates there is recurrent laryngeal nerve as well as superior laryngeal nerve paralysis. Clear? So whenever you affect both recurrent laryngeal nerve and superior laryngeal nerve together, then only you will be getting a cadaveric portion. So you have to be careful about it. These are the different portion of the vocal cords. But a good recap, let us do. Your recurrent laryngeal nerve, you know they are going to supply all the intrinsic muscles of the larynx, which means they are going to supply both abductors as well as adductors of the larynx. But when you damage the recurrent laryngeal nerve, what you're going to result? You're going to result in a very, very important phenomenon called hoarseness of voice. Or in severe scenarios, patient can even go for a respiratory failure. I'll tell you why they go for respiratory failure in some time. You will understand when I show the diagrams. Similarly, your external branch of the superior laryngeal nerve, when this is affected, usually are going to involve only one muscle, that is cricothyroid muscle. You know the cricothyroid muscle is important for raising the tone of the voice, which means raising the pitch of the voice. Cricothyroid muscle is really important. So which means when you damage the external branch of the superior laryngeal nerve and you reduce the, which means the patient cannot raise the tone of the voice and the voice will become husky. Clear? When you affect the internal branch of the superior laryngeal nerve, so this is something different because internal branch of the superior laryngeal nerve will result in anesthesia. Anesthesia of the area or the mucosa above the vocal folds. So above the vocal folds, that sensory supply is really important, and that is the one that prevents you from getting aspirated, because when you have that sensation only you can cough out, or you will prevent that movement of the food or any other water particles into your respiratory tract. So because of the anesthesia that is going to be generated above the vocal folds, there is a high risk of aspiration. There is a high risk of aspiration. Clear? Similarly, when you are going to injure both the recurrent laryngeal nerve and the superior laryngeal nerve, again there is a very, very high risk of aspiration and death. Clear? So these are some of the basic understanding that you have to do. But anyway, this is only the start, but let us understand in a much better way by using all these diagrams. So here I have told you normal and different varieties of recurrent laryngeal nerve injury, and also what will be the portion you will be seeing in combined recurrent laryngeal nerve and superior laryngeal nerve injury. But apart from that, since the recurrent laryngeal nerve is supplying both abductors and adductors, only in complete paralysis, you will be affecting both abductors as well as adductors. Only in a complete recurrent laryngeal nerve paralysis or a complete recurrent laryngeal damage, you will be resulting in problems of both abductors as well as adductors. Suppose if you are having only incomplete RLN damage or incomplete RLN paralysis, recurrent laryngeal nerve paralysis, you will be causing only abductor problem predominantly than the adductor problem, which means the abductors are affected more than the adductors. This is again a very, very important thing, because this abductor involvement more than the adductor involvement is explained by two different hypotheses. One is called Siemens law, and second one we call it as a Wagner and Grossman hypothesis. Wagner and Grossman hypothesis. Even though both tell different reasons, but ultimately what they are trying to tell is abductors are more affected than the adductors in recurrent laryngeal nerve paralysis. Why? Because Siemens law tells that phylogenetically or evolution-wise, abductors are newer compared to the adductors. Something that is evolutionary newer are more prone for damage. So that is the reason abductors are more affected than adductors. And Wagner and Grossman tells that the cricothyroid muscle can adduct a little bit. So which means they are functioning as a little adductor. So that is the reason why even in RLN palsy, cricothyroid is intact, means they might adduct a bit and can result in adduction than abduction. So this is what Wagner and Grossman hypothesis. And the most important point to note here is cricothyroid can adduct a little bit. So I can write here cricothyroid can adduct a bit. Not completely, but to an extent they can adduct. So again, this is really important. Remember, when your entire muscles are paralyzed, which means how a cadaver will look like, how a dead body will look like, all the muscles in the body are paralyzed, which means it will look in a cadaveric position. So which means this cadaveric position means entire muscles are paralyzed. All the muscles means in the larynx, it means cricothyroid as well as the intrinsic muscles of the larynx, which again means combined paralysis of recurrent laryngeal nerve and superior laryngeal nerve. Clear? So when both are paralyzed only, you will be resulting in cadaveric position. That's very important again. Okay, normally when you are trying to speak, when you are phonating, what will be the position? So in a normal person, both the vocal folds should be dead straight in the midline, in the median position. Similarly, when you are doing inspiration, obviously both the vocal folds should abduct to give way for the air that is going into the respiratory tract. Both are going to abduct very nicely. Fine. When you have a unilateral incomplete recurrent laryngeal nerve paralysis or recurrent laryngeal nerve injury, unilateral means, let us put right side for this example, unilateral incomplete. So what's going to happen here? The right side is damaged. This is the abnormal side and the left side is the normal side. So during phonation, the left side should normally adduct because they are having normal muscle, normal supply. So adduction is happening. Similarly, on the abnormal side also, that is on the right side, again adduction is possible because adductors are still intact and abductors are the one that will be weaker in patients with incomplete recurrent laryngeal palsy. I've told you some time back. So they can still adduct and the cords may be looking in the median position. So which means even on the abnormal side during phonation, cord will be in the vocal folds will be in the median position. But what will happen during inspiration? During inspiration, the normal side is going to abduct for sure, but the abnormal side will not abduct at all and still it will be in the median position only because here adductor overaction will be more than the abductor action because that is relatively adductors are overacting. So that's the reason they will still be in the median position. Clear? They will not move at all. So unilateral complete paralysis. In complete paralysis, both abduction as well as adduction is not possible, but they cannot be in the cadaveric position because cricothyroid has a bit of adducting function, not completely, but little adducting function is there. So that's why the vocal cords will be in the paramedian position. They will not be in the median position, nor they will be in the cadaveric position. Why not in the cadaveric? Because a little bit of adduction caused by the cricothyroid muscle. So they will be in the paramedian position, but at the same time, other side will be in the median position. So which means this is the normal side, this is the abnormal side. So which means I am taking a right unilateral complete RLN palsy. But the good thing about this is definitely this patient will have hoarseness because why they have hoarseness? Unilateral complete paralysis, they will surely have hoarseness. Why? Because the cords are not approximating. You can see a gap here. Cords are not approximating. But remember, this healthy cord or healthy vocal fold that is present on the normal side sometimes may go to the other side and they make it approximated with the abnormal side. So if the normal side vocal cord may sometimes go to the other side over time. This happens with time. So they can go to the other side and they can now approximate with the abnormal cord and the hoarseness usually improves with time in this patient. Clear? Similarly, what will happen during inspiration is again, since it's a complete paralysis, that will be located in the paramedian position only because here the abductor is equal to adductor weakness of the intrinsic muscles plus normal cricothyroid function. So that's why they are in the paramedian location. But the other side will be going for good abduction. But on the involved side, you will not get a good abduction. It will be located in the paramedian position only. Similarly, if we move on to the bilateral incomplete. Bilateral incomplete means since both sides you have incomplete paralysis, so this side is abnormal, both sides are abnormal. So here again adductor action will be more than the abductor action because abductor weakness is more and relatively adductor is overacting. And similarly on the other side also your adductor action will be more than the abductor action as well. Okay, phonation. During inspiration, again the same problem, they cannot abduct because here the adductors are overacting than the abductors. Again here the adductors are overacting than the abductors because the abductors are actually weak. That's by different laws I told you already because it's incomplete. That's why. So here you can see during inspiration also the vocal cords are not moving at all. That's why they go for respiratory failure. The air cannot move inside the respiratory tract. Bilateral complete. Bilateral complete means here both sides abductors as well as adductors will be damaged, which means both sides your vocal folds will be at paramedian location. Why? Because still some adduction is possible with cricothyroid. That's why they don't go for the cadaveric portion. But they maintain the paramedian portion because of the little bit adducting function of the cricothyroid. But they can't do anything because it's bilateral complete. Again, both will be located in the paramedian portion. Complete. Bilateral complete. Paramedian portion. Clear. When you have a unilateral superior laryngeal nerve as well as the recurrent laryngeal nerve, during phonation, let us assume this is on the right side, which means on the normal side, that is the left side, you are having normal approximation, but on the abnormal side, they will be in the cadaveric portion. Because this side, you are affecting all the intrinsic muscles that cause abduction as well as adduction, because it's a full paralysis, and superior laryngeal nerve will affect the cricothyroid also. So they're going to have cadaveric portion absolutely. And during inspiration, this normal side will go for abduction, and this will still look in the cadaveric portion, which means they will not move from the cadaveric portion, which means cadaveric portion means you have a combined RLN and SLN palsy. So similarly, when you have a bilateral RLN SLN palsy, both the sides you are going to end up with the cadaveric portion at all the cost. Both sides it will be cadaveric only. And irrespective of whether you phonate or try to phonate, or irrespective of whether you try to breathe, it will be in the cadaveric portion only. So remember, the most important problems with bilateral RLN palsy, with bilateral recurrent laryngeal palsy, is respiratory failure. Respiratory failure. The most common problem with unilateral recurrent laryngeal palsy is hoarseness of voice. Hoarseness of voice is the most important problem with unilateral recurrent laryngeal palsy. In the bilateral recurrent laryngeal palsy, the problem is respiratory failure, because either they don't move at all or they move very little. Remember, the opening is very small. Clear? But remember, normally it should open very widely like this. But here the opening is very small, so probably that is the reason they don't get sufficient air and they go for respiratory failure. So this is the problem. But whereas in a combined RLN and SLN palsy, you are going to probably result in high risk of aspiration and death, because the vocal cords will not close at all at any cost. So which means there is a lot of risk that all the food particles and whatever you eat or whatever you drink might get inhaled and enter the respiratory tract and might result in aspiration pneumonitis and die. So this is the problem in this condition. So we have discussed in detail about the different positions of the vocal cords in different conditions. The causes is not the cup of tea right now, because this is beyond the scope of the current discussion of the topic. So with this, you just have to understand the different positions of the vocal cords. You might get some image-based discussion, so that where you can get a lot of these positions, so where you might be asked about the what is the injury, which nerve or what combination of nerves are injured. So with this, let us move on to a little bit of microscopic anatomy of the thyroid gland. You know, the basic functional unit of the thyroid gland is going to be the follicles. So this is a single follicle. So this is the basic functional anatomy of the thyroid gland. So these follicles are going to be lined by a particular type of cell called as thyroid epithelial cells. You can see this area which I am shading in blue. So these are the thyroid epithelial cells. You can see these are the thyroid epithelial cells. At the same time, you can see the colloid, isn't it? So this is the center of the follicle, which contains colloid, where the thyroid hormones are actually produced. So in a simple nutshell, what these follicular cells do is, these follicular cells, this is called a basolateral side and this is called a apical side. In the basolateral side, you have a lot of blood vessels that are going on and the capillaries that will be going on. So what they essentially do is they take up amino acids and iodine from the basolateral side, and they process them and they produce a protein called thyroglobulin, which is spitted into the colloid in the follicle, and they are also going to release this iodine. At the same time, this iodine will become organified. This iodine will get attached to the thyroglobulin, and the thyroglobulin iodine reaction will take place, and they're going to form the thyroid hormones like T3, T4, MIT, DIT. We'll discuss in some time. The next video we'll be discussing about the physiology. That time I'll tell you what is MIT, DIT, T3, T4. They're going to produce thyroid hormones. These thyroid hormones will be again taken up by the cell and they'll be released into the blood. Isn't it? Here you have the blood, the capillaries. So again they'll be releasing into the blood. So which means they produce the thyroid hormones in the colloid only, and they take up these thyroid hormones and they finally release into the bloodstream. So this process is something, you have a lot of molecules and transporters involved. We'll discuss in the physiology, but this is a very basic principle that is happening in the thyroid gland. So this is the basic functional unit, that is the thyroid follicle. And the colloid is the place where your reactions that forms the thyroid hormones are taking place. And these follicular epithelial cells are the basic thyroid cells which are going to perform this particular function. And you have another type of cells that are located in the thyroid gland. Those, those are the C cells. It's not shown here. So you have called C cells, or otherwise referred to as parafollicular cells or C cells of the thyroid. Remember, they don't have any direct contact with the follicle. So they don't have any direct contact with the follicle, which means they just secrete one important hormone called calcitonin. Usually this calcitonin is generated from a precursor molecule called procalcitonin. Actually, procalcitonin is a very important marker of sepsis in the ICU. I mean, used as one of the important markers, but again, there are a lot of controversies in whether to use it or not. But it's considered as one of the important marker of severe sepsis in ICU patients. So that's the importance of the procalcitonin. But anyways, this procalcitonin, the N and C terminal peptides will be cleaved from this procalcitonin, and finally you will get the calcitonin, which is a very important hormone for calcium homeostasis, which we'll discuss later on when we are going to discuss about the parathyroid and the calcium. So these are the parafollicular or C cells of the thyroid gland. Because the embryology is different from that of the thyroid gland, so they just migrate and locate within the thyroid gland, but actually the parafollicular cells are originating from a completely different pharyngeal arch, which again we'll be discussing the embryology in some time. So this is the basic microscopic anatomy of the thyroid gland. Clear? So once you have understood the basic microscopic anatomy, let us move on to some of the embryological aspects of the gland. It is quite cool and very simple to understand the embryological aspects of the gland. In that, the most important to understand is where the thyroid originates from. Thyroid is going to originate from the endoderm. You have to be very sure about that. The first thing that you have to know is they are going to originate from the endoderm. But where from the endoderm? Where is the question if being asked? You have to answer, it is going to originate from the two important swellings that form the tongue, actually. So the tongue is formed from two important swellings. One, this tuberculum impar, that is originating from the first arch usually. And you have a cupola. Cupola has multiple. So this is the cupola, this is the hypobranchial eminence. So cupola means all these are called cupola, which means cupola is going to be formed by a second, third as well as fourth pharyngeal arch. But cupola of the second pharyngeal arch, this blue color one, that's what you're going to take about. So in between these two structures, so the tuberculum impar of the first pharyngeal arch, which is going to give rise to the tongue obviously, and the cupola of the second pharyngeal arch, so this again going to give rise to the tongue obviously, and between this two areas you are going to have a common area, small area, and from that particular endoderm only you get something called a thyroid diverticulum, which means that endoderm proliferates and gets split from that area, and that is what we call as a thyroid diverticulum. The area that splits off, that comes off from that particular endoderm, forms a foramen, and that's what we call as a foramen cecum. You can see it in the adult tongue also, isn't it? So that's called a foramen cecum. Clear? So before even going to that, let me tell you a brief some of the anatomy of the pharyngeal arches. So these are the first arches, second arches, third arches, and fourth arches. And each arch will have a specialized nerve, and each arch is going to give rise to their specialized muscles, and each arch is going to give rise to specialized skeleton. At the same time, in between the arches, you are going to get some thing called pharyngeal pouches also, And these pouches also are going to give rise to some important structures. So let us see in a nutshell. This first pharyngeal arch, we call it as a mandibular arch. And the important nerve of this arch is the trigeminal nerve, especially the maxillary and the mandibular nerve, 5-1, 5-3. And the muscles they are going to supply and the muscles they are going to form is the muscles of mastication. These are the masticatory muscles. What are the muscles of mastication? You have the masseter, then you have the temporalis, then you have the lateral and the medial pterygoids. Apart from that, they also form the anterior belly of digastric, not the posterior belly. Posterior belly is from the second arch. They are going to form the anterior belly of digastric, and they can also form a muscle called mylohyoid. So this mylohyoid is going to form the floor of the oral cavity. You know that it's going to be here, floor of the oral cavity. And they're also going to form two different tensors. One is tensor palatini and second one is tensor tympani. So both these muscles are from the first arch only. And skeleton wise, they are going to form the maxilla and the mandible, obviously. And they're also going to form the zygomatic arches, zygoma. And they're also going to form a part of the temporal bone. Not the complete temporal bone, a part of the temporal bone is formed by the first arch only. And they're going to form the muscles of the middle ear and the two muscles, not the stapes, except stapes, other two muscles, malleus and incus, are going to be from the first arch only. Apart from that, you have the Meckel's cartilage, and then you have the sphenomandibular ligament. All these things are also coming from the first arch, which is not theoretically important for exams. And the pouches, the first pharyngeal pouch. If you want to know what is pouch, you can see here there is some pouch-like structure that is happening here, isn't it? You can see here. So these are the pouch-like things that are happening in the between the arches. So you have first, second, third, and fourth pharyngeal pouches. So similarly, the first pouch is going to result in a eustachian tube and tympanic cavity or tympanic cavity. Tympanic cavity is nothing but the middle ear cavity, and they're going to form the eustachian tube as well. Similarly, the second pharyngeal arch is also referred to as the hyoid arch, and the nerve of the second pharyngeal arch is the seventh cranial nerve. And the muscles, they are going to be supplied. Obviously, it's the facial nerve, so muscles of facial expression. Muscles of facial expression. And they're going to supply the posterior belly of the digastric. And they're also going to supply one very, very important muscle called stapedius. You know that. Stapedius. And the second muscle they're going to supply is stylohyoid. So that's why I refer to as PFS into 2, but no need of that kind of complicated mnemonic. So muscles of facial expression, posterior belly of digastric, because anterior belly supplied by the is coming from the first arch, and stapedius, obviously you know it's facial now, and stylohyoid. Clear? And the skeleton that they're going to form is nothing but the one of the important middle ear bone, that is the stapes. Stapes will be formed by the second arch only. At the same time, they can also form the styloid process. And since it's called as hyoid arch, they form a portion of the hyoid bone also. What portion of the hyoid bone they form? So a portion of the hyoid bone. Clear? And they form the stylohyoid ligament. How first arch formed the sphenomandibular ligament, similarly second arch will form the stylohyoid ligament. And portion of the hyoid, in the sense they will be forming the lesser horn and the upper portion of the body of the hyoid bone. Clear? They will be forming the lesser horn and the upper portion of the body of the hyoid bone. And the pouch wise, they form the palatine tonsils and the tonsillar fossa. They are going to form the palatine tonsils and the tonsillar fossa, second pouch. And clearly it's been mentioned here, they are forming the palatine tonsils already. And the third arch and the nerve of the third arch is going to be the glossopharyngeal nerve, that is the ninth nerve. And what they are going to form, what are the muscles they are going to form? Only one muscle, that is the stylopharyngeus. Stylopharyngeus is the only one muscle they form, and the bone they are going to form is the part of the hyoid bone. So how your second arch is forming the lesser horn and the upper portion of the body of the hyoid bone, similarly they are going to form the greater horn. So they are going to form the greater horn and the lower portion of the body of the hyoid bone. lower portion of the body of hyoid bone. Here you know it is the lesser horn and the upper portion of the body of hyoid bone. Clear? Similarly, the third pouch is going to give rise to two important structures. One is the inferior parathyroid gland. Inferior, not superior. Third is inferior, fourth is superior. So inferior parathyroid gland and probably the thymus. Clear? And you have the fourth arch. This fourth arch, the most important muscles of the fourth arch are the laryngeal muscles, especially the intrinsic muscles of the larynx. Intrinsic muscles of the larynx are going to come from the fourth arch only. So usually in textbooks, if you see, they would have given as fourth to sixth arch, but that's also correct. But fourth is the one that's the major contributor here. And similarly, remember in the fourth arch, I wrote here 4, the important nerve that supplies the fourth arch is the 10th nerve, that is the vagus nerve. So for the fourth arch, it is the superior laryngeal nerve, especially the external branch and the internal branch of the superior laryngeal nerve is going to supply the fourth arch. And if they ask you about the sixth arch in general, they will be supplied by the recurrent laryngeal nerve. So this is the nerve of the sixth arch. But overall, the fourth to sixth is always by the vagus nerve only. So they're going to supply all the intrinsic muscles of the larynx because they have the recurrent laryngeal nerve. Similarly, they are also going to supply the cricothyroid because you have the superior laryngeal nerve. With this itself, you can tell they are going to supply the cricothyroid as well. And at the same time, they are also going to supply the pharyngeal constrictors. This vagus nerve in this arch is also going to supply the pharyngeal constrictors, and their pharyngeal constrictors are actually originate from the fourth arch only. And skeleton wise, what are they going to form? Skeleton wise, it's not that much. They are going to form the laryngeal cartilages. That's all. It's very simple to understand. They are going to form all the laryngeal cartilages. You know, so many laryngeal cartilages are there, right from the arytenoid, then you have, cuneate, lot of bones are there. Clear? So, all the laryngeal cartilages are going to be formed by the fourth arch only. Similarly, the fourth pouch is going to give rise to the superior parathyroid gland. Superior parathyroid gland is going to form from the fourth pouch only. At the same time, they are also going to give rise to the parafollicular cells. Parafollicular cells are C cells which are going to secrete the calcitonin, which we saw already. Clear? Parafollicular cells are the C cells of the thyroid gland. Clear? So these are the different arches that you have to know in the first place. But where the thyroid is originating from, but before that, let us see the tongue in the first place. So you know where the tongue originates from. Tongue basically originates from all the four arches. Tongue originates from all the four arches. So with the most contribution from first arch is going to form the anterior two-third of the tongue. First arch is going to form the anterior two-third of the tongue along with the little contribution from the second arch. They are going to form the anterior two-third. You know very well, that is why the tongue's nerve supply is also split between these two nerves in the anterior portion. So anterior portion, the general sensory obviously will be from the first arch, isn't it? So because anterior two-third is contributed the first and the second only. So general sensory on the anterior portion will be by the trigeminal nerve, especially the mandibular nerve, and how they are going to supply through the lingual nerve. And again, the anterior two-third taste, special sensory, is going to come from the second arch because I told you with a little contribution from the second arch, isn't it? So taste is going to be from the facial nerve. And how? They are going to give rise to the cauda tympani branch in the middle ear. And again, they supply the anterior two-third through the lingual nerve. Through the lingual nerve only, they also supply. Similarly, you know, this third is going to contribute to the third and a little bit fourth. The third especially is going to contribute to a particular area of the tongue called posterior one-third of the tongue. Posterior one-third of the tongue, or otherwise the root of the tongue. You know that the posterior one-third of the root of the tongue is contributed by the third arch. Obviously, only nerve of the third arch is the ninth nerve, which means it's very clear the general sensation as well as the taste will be carried by the ninth nerve only. And you have the fourth arch. The fourth arch is going to give rise to the extreme posterior aspect of the tongue extreme posterior portion of the tongue. At the same time, they are also going to form the epiglottis. And similarly, the general sensation as well as the taste in these areas. Even epiglottis can taste a little bit, but not even though the taste buds are not prominent there. So both are going to be carried by the nerve of the fourth arch, that is the 10th nerve, vagus nerve. So this is how the tongue is divided, and everything is based on the embryological anatomy only. And in that, if they ask you where the thyroid is formed, thyroid, again, I am recapping you, it is formed between the tuberculum impar of the first arch and the cupola of the second arch. So in between, you are going to have a pharyngeal chunk. That time it's a primitive pharynx. Later on, it becomes the tongue. You have to understand. These are the pharyngeal arches. This is a primitive pharynx. From this, you get different structures. Later on, it might become the tongue. But initially, it was a primitive pharynx. That time, this in between these two structures, there is a chunk of endoderm that separates out, and they form the thyroid gland, thyroid diverticulum initially, which is later going to form the thyroid gland. And this portion of the separated chunk of endoderm going to form a foramen called foramen cecum. And you can see this is the foramen cecum. That's the opening that is created because of the removal of a chunk of an endoderm from that particular area. This is the ventral side of the pharynx, the primitive pharynx. Later on, this area is going to form the tongue as well. You can also see that when the thyroid descends down, the thyroid continues to establish communication with the foramen cecum. That is the starting point of the thyroid. That from there the thyroid started. That's the embryological evidence from where the thyroid started. So that is actually seen in adults in the base of the tongue, in the anterior two-third itself. So that is where the thyroid has started. So they still establish communication, at least embryologically. So this connection embryologically with the foramen cecum as the thyroid descends down to its regular location is what we refer to as a thyroglossal duct. Clear? And you can also see a lot of other crucial information in this diagram. You can see that this is the fourth pouch, and this is going to be the fourth pharyngeal pouch. And from the fourth pouch, you are forming the superior parathyroid gland, which is becoming the superior parathyroid gland. And they also differentiate into a entity called ultimobranchial body. This ultimobranchial body is coming from the fourth arch only, which is going to ultimately form the C cells of the thyroid gland. Similarly, you have the third pouch here. From the third pouch, they form the inferior parathyroid gland, which is going to enter the thyroid, and they form the inferior parathyroid glands from the third pouch. And they also differentiate to produce the thymus, which is going to enter the mediastinum, migrate to the mediastinum. Clear? So this is something again very crucial to understand. And let us see another image. So you can see here, this is the foramen cecum here. That is the primitive pharynx, primitive pharyngeal gut there, which is going to later on differentiate into tongue in that area. And the connection with them is the thyroglossal duct. You can see that as well. And you can see this is the thyroid diverticulum. Initially, it is called as a thyroid diverticulum. Later on, it will become the thyroid gland. This diverticulum is typically bilobed because it has to give rise to two lobes of the thyroid gland. Clear? And finally, this is the adult concept. So where you can see in the adult, this is the foramen cecum at the base of the tongue, in the anterior part of the tongue, where you can see this is the migratory portion of the thyroid gland towards the lower anterior portion of the neck. So this thyroglossal duct in the distal most portion, usually most of the thyroglossal duct will obliterate. So this is the entire tracking portion of the thyroglossal duct, and usually all of the thyroglossal duct will obliterate. So they won't be there. And the distal most portion of the thyroglossal duct may actually have a remnant called the pyramidal lobe of the thyroid gland. May form a remnant called pyramidal lobe of the thyroid gland. That is nothing but the distal most portion of the thyroglossal duct. And again, for the same reason, you can see ectopic thyroid anywhere. Ectopic thyroid tissue anywhere throughout this location of the thyroglossal duct, anywhere you can see ectopic thyroid tissue, very commonly near the foramen cecum itself. Fine. At the same time, if you have some remnants of the thyroglossal duct in between, not the pyramidal lobe, I'm talking about in between, if you have remnants, you are going to result in something like this called as a thyroglossal cyst. Remember, thyroglossal cyst is again going to have all the characteristics of a thyroid gland, that is its midline mass. It's a midline mass and cystic lesion, and it's going to move with deglutition and swallowing. Deglutition and swallowing. So this is very crucial to clinically differentiate with another entity called branchial cyst. Branchial cyst usually will be more lateral near the sternocleidomastoid muscle. At the same time, they will not move with deglutition or swallowing. So that's one important thing. That's how you differentiate between a branchial cyst and a thyroglossal cyst. And sometimes thyroglossal cyst might become infected and they can go for some cancer also. There is some evidence that they can go for cancer also, papillary thyroid cancer. Or sometimes this thyroglossal cyst may have other complications, might rupture and they can produce a sinus outside and leak also. These are some complications. If there is any complication, you are going to perform an operation called cyst trunk operation. That is for the thyroglossal cyst. So this is one of the other important embryological anatomies that you have to know. And final question you might ask me is why tongue muscles are supplied by your hypoglossal nerve, because remember the tongue muscles are not coming from the pharyngeal arches. You have to be very clear about that. Even though tongue, lot of this endodome, ectodermal things are coming from these arches, but the muscles per se are not coming from the pharyngeal arches and pouches. The tongue muscles are actually coming from the occipital myotomes. So from there only they are coming. Clear? So since they are coming from the occipital myotomes, they carry the hypoglossal nerve along with them. That area is supplied actually by the hypoglossal nerve. So that is why tongue muscles are actually supplied by cranial number 12 predominantly. That is hypoglossal nerve. Very, very important. Clear? So these are some of the important embryological aspects of the thyroid gland. And final point that is also asked in some 2-3 times in certain All India exams are, when does the thyroid hormone starts getting synthesized in the fetus? Thyroid hormone. The first evidence of thyroid hormone you can see around 11 weeks. That's the answer. Very important question. The first evidence of thyroid hormone in the fetus will be seen around 11 weeks of gestational age. Clear? So these are some of the important points that you have to understand about the thyroid glands and the related anatomy and the embryology. In the next section, we'll be seeing on the physiology of the thyroid gland and the thyroid hormones. So till that, so stay tuned and thank you for patient listening.